Hello, and thank you for joining us for the Native Center for Alcohol Research and Education webinar series. Our agenda today includes a brief overview of Initiative for Research and Education to Advance Community Health and Partnerships for Native Health. We will then move on to our Native CARE presentation, which is Alcohol-Exposed Pregnancy Prevention in American Indian Communities, a new randomized controlled trial of the preconceptual approach, with Drs. Michelle Sarche and Jessica Hansen. We will close with question and answer, and at the end of this webinar, you will receive a survey link. This webinar is also being recorded and will be on our YouTube channel and on our website at t4nh.org. Next slide. The Initiative for Research and Education to Advance Community Health, or IREACH, at Washington State University challenges the status quo and advances community health through partnerships and collaboration. Next slide. The structure of IREACH includes research around Native health, Native Hawaiian and Pacific Islander health, rural health and health networks, Latino health, and addiction studies. We work with the colleges of medicine, nursing, pharmacy, engineering and architecture, communication, and veterinary medicine. Next slide. Partnerships for Native Health conducts community-based research and education to improve health and reduce health disparities among American Indians, Alaska Native, Native Hawaiians, and Pacific Islanders. It is a prototype for program development for new and novel programs at Washington State University. We focus on achieving health equity, community outreach and engagement, and training and education. We have over 160 partners across the country, including tribal colleges, Native organizations, tribes, and universities. Next slide. Partnerships for Native Health include 7 satellite centers across the country in Washington, Colorado, Oklahoma, New Mexico, Alaska, North Carolina, and Minnesota. Next slide. Research topics include alcohol use disorders, substance use prevention, smoking and nicotine dependence, suicide prevention, mental and behavioral health, homelessness, high blood pressure, diabetes, stroke risk reduction, cervical cancer prevention, colorectal cancer screening, and cognitive impairment and Alzheimer's disease. Next slide. The Native Center for Alcohol Research Education, or NCARE, aims to optimize alcohol intervention research for public health in general and our Native community partners in particular. We accomplish this goal by collaboratively engaging with research project teams and the pilot projects to conduct research that yields high-quality data while simultaneously meeting the unique needs of our partners. This research is supported by the National Institute on Alcohol Abuse and Alcoholism under award number P60AA026112. And now I would like to hand it over to Dr. Michelle Sarche and Jessica Hansen for our main presentation. Thank you.
Hi, everybody. Thank you, Crystal. My name is Michelle Sarche, and let's get into our presentation here. Next slide, please. So this is our group of presenters who have helped prepare our material for today. From left to right, we have Marie Gross, Deidre Buchwald, myself, Jessica Hansen, Tara Doshino, and Marcia O'Leary. Next slide. Our goals for today are to discuss the importance of a preconception approach to alcohol-exposed pregnancy prevention, or AEP prevention, review the current project to test the efficacy of Native CHIOCES for AEP prevention among American Indian women, and to share information about the community partnership and setting for the current project. So next slide, please. I'm going to turn it over now to Jessica, who is going to address that first goal and to share with you some information about the importance of a preconception approach to AEP prevention.
Thank you, Michelle, and thank you everyone for being on this webinar. Next slide, please. So it's well established that drinking during pregnancy has the potential to cause lifelong problems in children and adults. And it's completely 100% preventable. We do know that most women do stop drinking completely when they find out they're pregnant. The issue that we as public health professionals run into is that when they find out they're pregnant depends on if they're planning a pregnancy or not. Little is known about the threshold of alcohol that cause FAS. So there's a lot of research that still needs to be done. What we do know is that nutrition can play a role, genetics can play a role, but we don't really know how the details of all that. And not all mothers who drink during pregnancy have children born with fetal alcohol syndrome. So there are some doctors that believe that any alcohol can put the baby at risk. And there's others that disagree with that. We do know that drinking at high levels, binge drinking or drinking at heavy levels, especially during the first 12 weeks of gestation, is particularly harmful. And so what I have on this slide is comes from a National Geographic article from 1992, which is fairly old, but still very relevant today. And so this is a woman whose child is impacted by prenatal alcohol exposure. And she talks about how she was drinking very heavily until she found out she was pregnant. And she did not find out she was pregnant until she was about 2 months because she was not planning a pregnancy. And so where we really have concern is the amount of alcohol that an individual drinks. So binge drinking is defined as 4 or more drinks on any one occasion, and heavy drinking is more than 7 drinks in a week. We're also concerned about the timing of drinking. Next slide. So if you look at this figure, this very well-known figure from Dr. Claire Coles, note the critical time period of alcohol exposure. So kind of the first 2/3 of that slide is that first trimester. This is often a time when a woman may not know she's pregnant yet, especially if she's not planning a pregnancy. And this is a very critical period of fetal development. Next slide, please. And so within the past 15 to 20 years, there's been a huge focus on primary prevention of fetal alcohol syndrome. A lot of this work comes from the Centers for Disease Control and Prevention, and it's looking at emphasizing preventing alcohol-exposed pregnancy before a woman becomes pregnant. And so the Centers for Disease Control and Prevention, the CDC, states that any sexually active woman of reproductive age who's drinking alcohol, especially at heavy or binging levels, and not using effective or any contraception is at risk for an alcohol-exposed pregnancy. And so through a national study, they found that the prevalence of alcohol-exposed pregnancy risk among US women aged 15 to 44 is about 7.3%. And we know that in some populations, that number can be even higher. Next slide, please. So in this national study, they found the women who are most at risk for having an alcohol-exposed pregnancy were women who were between 25 to 29 years old, women who were married or cohabitating, women who had had a child before, had had 1 live birth before. It was also higher among women who smoke, positively associated with levels of education, and it, very importantly, did not differ by race or ethnicity. Again, this is a national study, and some of our anecdotal information tells us that these statistics might be different in other populations. Next slide, please. So one of the main efforts to prevent alcohol-exposed pregnancy with preconception women is called CHIOCES. Next slide, please. So CHIOCES, it's a long acronym. We just say Project CHIOCES, but CHIOCES stands for Changing High-Risk Alcohol Use and Increasing Contraceptive Effectiveness Study. Again, we typically call this CHIOCES. And this was funded by the CDC, again, late 90s, early 2000s, and it was focused on a preconception approach to the prevention of alcohol-exposed pregnancies. Participants in this original RCT, randomized controlled trial, were women, non-pregnant women from various settings in 3 southern states. Each participant received personalized feedback on their risk for alcohol-exposed pregnancy. And the heart of CHIOCES is its use of motivational interviewing. And so some of the activities based on motivational interviewing are decisional balance exercises, a readiness ruler, a lot of goal setting, and really trying to work with the woman where she's at in terms of changing either her alcohol consumption or her use of contraception. And another large part of the CHIOCES intervention is its use of the trans-theoretical model, or the stages of change model. And so again, because Choices wants to work with the woman wherever she's at in terms of behavior change, there's a lot of focus on goal setting and trying to move her along those stages of change. And so the results of this randomized controlled trial found that the Choices intervention significantly reduced risk for alcohol-exposed pregnancy. And there were statistically significant differences in risky drinking and contraception between the two groups, the intervention group and the control group. The original Choices intervention utilized a 4 in-person intervention. Now, there's been other studies that have looked at telephone-based interventions, and there's been some very recent focus on web-based interventions. But today we'll talk mainly about the in-person intervention. There's also been research that's compared 2 sessions versus 4 and have found no differences, which will be important as we describe our Native Choices. Next slide, please. And so Native Choices came about when a tribe in the northern plains of the United States became very interested in preventing alcohol-exposed pregnancies. And so this tribe applied and received a grant and really wanted to tackle the feasibility of this intervention with tribal communities. And so they subcontracted with a team that I was a part of, and this was really to look at the process, also the outcome, but really the process of implementing this in a tribal community. And so we had a lot of community meetings, we did a lot of presentations. The main focus of this was to introduce the project to clinics, to tribal health officials, and also to the community. We wanted to discuss questions, concerns, and next steps of how this would look. And so there were some logistical issues to be worked out, but we really wanted to look at how would this curriculum look for American Indian women. Next slide, please. And so some of the Native Choices adaptations that we made included culturally appropriate images and color, making sure that it was written at a certain grade level, reading level. We wanted to include common types of alcohol that were consumed in this community. And so at the bottom of this slide, you see a graphic that shows how the original Choices intervention really talked about alcohol. And we found that the women we were working with weren't drinking these types of substances. We also wanted to look at acceptability of contraception and also what was available for contraception, and also to frame the risk for alcohol-exposed pregnancy locally. Because as I said, although there's some national statistics on alcohol-exposed pregnancy risk, we did want to look at this very locally for the women we were working with. Next slide, please. We also undertook a validity and reliability study to make sure that the activities, the questions, the wording were done appropriately and made sense to the women that we worked with. And so we did both a content analysis and also a test-retest to look at how do women that we are working with respond to the actual curriculum, the Choices curriculum. Next slide, please. And so we implemented this intervention with approximately 195 Native women. We consider this to be it's a pilot study, sort of a pilot feasibility study, in which we looked at baseline, all women were at risk, but how many women were at risk at 3 and 6 months? And so we had a lot of different things to work out in terms of just practicalities of implementing this, but we did find very similar results to the original Choices intervention, in that the Native women enrolled in Native Choices for this preliminary study were at reduced risk for alcohol-exposed pregnancy. So we felt that this study showed that Choices can and does work with Native communities and has a lot of potential. Next slide, please. And so this slide really highlights the work that we've done up to this point in terms of making Native Choices appropriate for the American Indian women that we're working with. And so if you look at the phase 1, the design, getting community input, doing a validity study, and then doing some very strong preliminary testing. And all this information was vital to help us create what Dr. Sarche will now describe, our efficacy trial. Next slide, please.
Thank you, Jessica. So yes, I'm going to walk you through the study that's underway right now, a randomized controlled trial of Native CHIOCES. Next slide. So our efficacy study is actually one of 3 aims that's part of our broader Native CHIOCES study, which is part of the Native Center for Alcohol Research and Education that Crystal described earlier. So for our Native CHIOCES study, again, there's 3 aims. The first is what we're going to talk about in just a second, is to conduct a randomized control trial of Native CHIOCES, so following up on the work that Jessica has described, versus usual care for reducing alcohol-exposed pregnancy risk among American Indian women in a rural reservation setting. And we are also going to evaluate Native CHIOCES reach, acceptability, and sustainability. And we will conduct a cost benefit and cost effectiveness analysis of Native CHIOCES versus usual care. Next slide. But again, just to reiterate, we're going to focus on this first aim in the presentation today, because that's the phase of the study that we're in right now. And we'll be rolling out aims 2 and 3 a little bit down the road. Next slide. So I just wanted to highlight that also as part of our aim 1 activities, we are also gathering biomarker data, in this case blood spots, to do an analysis of something called PEth, which is phosphatidylethanol, which is a blood marker for alcohol use. So participating women can opt into this part of the study as well. And this is done totally anonymously and will be an opportunity to look at basically the correlation between self-reported alcohol use and blood markers, blood biomarkers for alcohol. So that is a part of aim 1, but it is not central. It's not being used necessarily as an outcome for our study, but I just wanted to mention that. We'll talk more about it in a little bit. Next slide. So our aim 1, again, focusing on aim 1 of the 3 aims for this study, is the RCT, and there are a set of intervention activities. So for our intervention activities, we have the 2 Native CHIOCES sessions that Jessica described already. Those are conducted in person in our research field office. Also, there is an optional contraceptive counseling visit that actually is built into the Native CHIOCES as well as the CHIOCES curriculum, but it does happen outside of the CHIOCES sessions, because that is something that is set up with a local community provider. And that happens if a woman opts to have that contraceptive counseling visit. That would happen between sessions 1 and 2. And then women can opt into receiving a small set of supportive text messages while they're participating in the study. Next slide. So eligibility for participating in our study is that women have to be American Indian or Alaska Native, between 18 and 44 years old, and that particular criteria aligns with the past research on CHIOCES. Be able to get pregnant, but not be currently pregnant. Have self-reported risky drinking in the last 90 days. Have had vaginal intercourse with a male partner in the last 90 days. Not be using effective contraception, and not living with someone enrolled in the study. Next slide. And again, just to highlight, when we say risky drinking, that is defined as heavy or binge drinking, and heavy drinking is having 8 or more drinks in a week. Binge drinking is having 4 or more drinks on one occasion. So that has to have, one of those 2 things has to have happened in the last 90 days to be eligible to be in the study among these other eligibility criteria. Next slide. So our hypothesis is that among women who are randomly assigned to the intervention group, the risk for an AEP will be reduced by 30% overall, because women will be either less likely to engage in risky drinking, again, based on self-report in the last 90 days, or more likely to use effective contraception, or both. Next slide. So this is our conceptual model. Basically, if you think of it as sort of inputs on the left and outputs on the far right, and then in the middle are sort of the mechanisms of change. So Native CHIOCES is really based on these motivational interviewing approaches. So that is an input, the contraceptive counseling visit, as well as the electronic messages. Basically everything I just described on the last slide, what the women in the intervention group are receiving. And we believe that we will affect change on the far right, again, reduce AEP risk by reducing heavy drinking and binge drinking, so essentially risky drinking, and increasing effective contraceptive use. We believe that that change will happen because of these things that are happening here in the middle. There'll be a greater sense of social support, greater knowledge about what are AEPs, alcohol exposed pregnancy, and FASD, as well as, again, really related to motivational interviewing, helping that readiness to change move from where women are at currently to the next level, to be ready to make some changes in our outcomes of interest. Next slide. So again, Native CHIOCES is part of the Native Center for Alcohol Research and Education. It's one of the 3 research projects that's happening as part of that broader center. So on the left, I have the constructs that we are measuring that are unique to our Native CHIOCES work, but we also want to capitalize on the fact that these 3 research projects are happening across 3 different populations. And so we're going to be also using measures that are common across all 3 of those research projects in different settings that have different aims. So let me just say on the left, unique to Native CHIOCES, we will be specifically measuring risky alcohol use, which we've already talked about, includes binge and heavy drinking, contraceptive use, AEP knowledge, social support, as well as social connectedness. And again, we're gathering that biomarker data, the PEF analysis. Those are unique to Native CHIOCES. And then on the right are the constructs that we're going to be measuring that are going to be shared across all 3 research projects. So some demographic information, substance use. The audit is a measure of alcohol use, but also gathering data on tobacco use, some health indicators, including depression, health-related quality of life, body mass index and pregnancy history, some measures of cultural identity and practices, including a measure of enculturation and one of spirituality. And then the economic evaluation will be happening for each of the research projects. Next slide. So I realize that the font is really small on this slide, but the main thing is really just the visual, the overall visual here, and I'm going to walk you through it. But it's really the anchors, if you hit the next slide, please. The anchors, the important takeaway here is that there are 4 data collection points. That's at baseline when women enroll into the study, 6 weeks post-baseline, 3 months post-baseline, and 6 months post-baseline. So those are the important, those are important anchors to think about this figure. So in between baseline, when women fill out that first survey before any intervention activities take place, and 6 weeks, they are randomly assigned either to our Native CHIOCES intervention group or to a waitlist control. So again, you can see if you go all the way down on that red line, women assigned to the waitlist control will be able to receive the intervention at the end if they would like it. But for our intervention group, that's to the left, the green boxes, between baseline and 6 weeks post-baseline, that's when all of the Native CHIOCES intervention activities are taking place. And again, that includes the 2 Native CHIOCES sessions, the optional contraceptive counseling visit, and the optional supportive text messages. Okay, so that's happening within that 6-week period. And regardless of whether or not women are able to complete all the activities, we will be gathering 6-week post-baseline data at that point, 6 weeks. And then again, between 6 weeks and 3 months, they're only receiving the supportive text messages, and then we'll do a 3-month post-baseline data collection. And then between 3 months and 6 months, there's nothing happening, but we would be looking at longer term, do those outcomes that we hopefully see at 6 or 3 months, do they maintain at 6 months? Okay, so after that 6 months post-baseline data collection point, the study is over for a given participant. Next slide. So to date, we have just started enrolling women into the study. We have screened 17 women, and these numbers may have even changed since a couple of days ago when I got these numbers, because we're actively enrolling every day. But we have screened 17 women. And again, if you think back to those eligibility criteria, 5 were not eligible for one reason or another on that eligibility criteria list, but 12 were eligible. And of those 12 eligible women, all of them consented or agreed to be in the study. And, they're randomly assigned, but it just so happens that they have equally ended up in the intervention and control group at this point. Next slide. And then if you can hit the down arrow, or the next, yeah, thank you. So what is here is this is our goal for recruitment across the 3 years. This is a 5-year project, but the 3 years that we will be implementing the intervention. So we're in year 2 right now. We have a total goal across all 3 of those years, those active study years, to recruit 350 women, half of whom would receive the intervention and half of whom would be on the waitlist control. So we're aiming for 100 women in this first year of data collection, which is year 2 of the project. And so we've just started. We have a ways to go, but we are hopeful that we will get to our goal certainly by the end of our 3rd year of study activities, or year 4 of the project. So you can just see there how we plan to enroll in each of those years. Next slide. So I wanted to acknowledge our entire research team here, and then I'm going to turn it over to Marie, who's going to share some information about the community context for this study. But this project is really a partnership across 6 different institutions. Washington State University, the team there includes Deidre Buchwald, who is the overall PI and the co-lead for this project here. Gladys Rowe, our research coordinator, Damon Cunningham, our study assistant at University of Colorado, is where I am at. Michelle at Sanford Health. We have Jessica Hansen, a co-investigator. And then we have our Missouri Breaks Research Industries team, Marcia, Marie, and Tara, who you saw on the slide at the very beginning. At the University of Minnesota, we have Rich Maclehose. He is a co-investigator and our methodologist. So he really helps us think through that study design and how we're going to analyze our data once we have it. And at the University of Texas Health Sciences Center at San Antonio is Dr. Marty Javers, who is heading up the PEP analysis process. Next slide. So like I said, I'm going to hand it over to Marie, who is going to share a bit about our community partnership and the setting in which our study is taking place. Thank you.
Good afternoon, everybody. My name is Marie Gross. I work with Missouri Breaks and am the site coordinator for this project. Next slide, please. So I work for Missouri Breaks. We're located in north central South Dakota, and we do projects with numerous Native American reservations in western South Dakota and North Dakota. So next slide. A little background on the area and the local culture. We have a Northern Plains background. Sioux people with the Dakota, Nakota, and Lakota tribal cultures. The people in this area started out, working with treaties, and then ended up becoming going to reservations. So started as nomadic hunters and gatherers, and went into subsistence living, where they were receiving commodities and living on handouts from the government. Next slide, please. The Great Plains region, this kind of just highlights how it went from a great reservation to several small reservations. And so there's 16 different tribes here, 6 tribal organizations, and kind of shows the layout in this area. Next slide, please. So when we talk about some of the community health disparities that we have, when you're looking at the Indian Health Service website, you can see that alcohol-induced deaths are some of the highest. They're the 5th highest all-cause mortality, and that it's a ratio of 6 to 1 when it comes to American Indians to the United States, all races, for alcohol-induced deaths. And also chronic liver disease and cirrhosis also has a high rate of mortality in the Native American populations. And this is general, not just specific to this area. Next slide, please. In the North Dakota and South Dakota, this is from the Centers of Disease Control, we have high rates of women with alcohol use. In North Dakota, it's 66%. And in South Dakota, it's 60% using it at high levels. And then also high levels of binge drinking. In North Dakota, 26%, and in South Dakota, 23%. And that's highlighted in the image that we see over on the right. Next slide, please. Finally, this is just some pictures of some of the areas out in western South Dakota, kind of highlighting some of the wild beauty that we get to have out here on these reservations. Next slide, please. Thank you.
All right, next slide, please. So we wanted to have time here for questions that you may have. So we are here to take your questions.
So this is Gladys at WSU. I'm going to be sharing the questions that pop up in the chat panel. There's a question and answer box in your Zoom feature. So if you do have a question, please feel free to type it in there. I will read it off and allow the presenters to respond to your question. The very first question that we have is from Christine, whose question is, how are you recruiting?
I'm going to let Marie speak to that. Is that okay, Marie?
Yep, absolutely. So right now, since we're just in the beginning phases, we're starting off with word of mouth, but we plan to put posters up in some of the community areas in our communities. And also we have had meetings with providers. We obviously aren't recruiting women who are pregnant, but we are hoping that we'll be able to help get with providers handing out pamphlets to people who might be interested. They, of course, wouldn't direct refer to our program, but just in general, if they feel like women might be interested, they could hand them a pamphlet. And the other thing we're doing is attending tribal community programming. There's tribal health there's tribal health fairs and other community projects that we're able to attend.
Great. I do have another question here to Marie. This is from Jill. Where are you located? What reservations are you working with in South Dakota?
We're not at liberty to talk about the specific reservations that we're located at.
Great. I have another.
I just wanted to comment on that. Yep. You know, I'm sure there's a range of participants on the webinar today, but I've worked with American Indian and Alaska Native communities, this is Michelle speaking, on various research projects over the last 20 plus years. And as a researcher, we're very used to protecting the privacy of individuals. That is obviously always front and center in our work as researchers. But in partnering with Native communities, it's also a pretty common practice to really, and different communities have different policies or preferences around being identified as the research partner. So we just tend to err on the side of caution in identifying the communities, again, just to protect privacy at that community level. But that doesn't mean that sometimes you won't see communities identified as the research partner or the research site. Again, it's really a community by community sort of choice or guidance that we follow. So I just wanted to comment as to why we at this point are protecting the privacy of the specific community that we're partnering with at this time, and really have just described our partnership in more of a regional sort of way.
Thank you, Maria Michelle. I have quite a few questions here now. So the next one is from Judith. When is the waitlist control first able to receive the intervention? Do they have to wait out the full 4 years?
No, they don't. And if you want to go back to that slide, Gladys, that has you get there, almost there, that one. So they would be able to participate after they complete their 6-month post-baseline surveys. So 6 months is basically the longest that they would have to wait before being able to participate in the intervention.
Great. The next question is from Amy. She asks, for the 5 women that weren't eligible for your study, what was the reason that made them ineligible?
Do you want to click down to the next slide?
Yeah, I can answer that. So we had one woman who came in who was over the age limit. We're recruiting between the ages of 18 to 44, and she was over the age limit. We had another gal who came in who was not drinking at risky levels. So we just have this screener, and the screener does its work. We don't necessarily check to see that they're eligible before we let the screener do that work. And then we had another one that was using birth control effectively. So we've had those 3 for sure come through. I know we've had questions asked about whether or not gender, like if like a woman who identified as male would be eligible to come through. And the question there is, as long as they're engaging in behaviors that might make them at risk for unplanned pregnancy, then yes, that person would be eligible to come through. So just that they have to be female and be having, drinking at risky drinking levels, and also not be using birth control effectively.
Thank you, Marie. I have a question from Selena asking, have you been successful with retention and maintaining contact? If so, what are your methods?
Yes. So we have our site assistant, Tara Ducheneau, and she has a few methods that she uses. We do text messaging, phone calls. We have utilized Facebook Messenger. Sometimes people use that more consistently, or their numbers don't change as often. And also just sort of the methods of knowing families and grandmas. We ask for a contact person for that, how to get a hold of them in the event that the numbers that they originally gave us aren't working. So those are all different methods that we use to keep a hold of people.
Okay, I have a question from an anonymous attendee. How are you integrating levels of change or individual goal setting from your theoretical models into your intervention? Are you monitoring or measuring levels of change?
Yeah, I can tackle this one. So we don't, it is based on the stages of change. Now, we don't specifically measure and try and calculate where they are. We have a lot of qualitative data, though, that can really highlight where they are in the stages of change. And so most women, when they come into the intervention, are in that pre-contemplation. So they're sort of thinking about changing, but not quite sure, haven't taken any actions. And so our goal by the end of the intervention, by session 2, is that they are either in the action stage, so they're actively making change. They've made an appointment with a healthcare provider to get on contraception. They've reduced their drinking, or they're at least setting goals to do that. And so, again, we don't specifically have measures for the stages of change model, but we do qualitatively, we can comprehend that. And there are a couple papers out there from other folks on the use of the trans theoretical model. And so if you look at some of the work by Karen Ingersoll and Mary Velasquez, I mean, they really tackle that issue. It's a very good question.
Okay, I have a in-conference room question here, so I'll ask Lucy to ask her question.
Yeah, I just was curious a little bit about the measurement of contraception, effective use of contraception. So if you could talk a little bit more about that. And then just out of curiosity, we know that some methods of contraception are more effective than others. So what is the method mix that is available to women? Is the study providing contraception, or what does that look like working with local health providers?
Yeah, so because we really want to work with a woman where she's at, we don't personally prescribe. I mean, we're not healthcare providers. We don't prescribe contraception. I believe there's probably free condoms available, but we don't prescribe contraception. But we do have very good relationships with Indian Health Service, and Indian Health Service has sort of the gamut of contraception, everything that you'd see in any other clinic. And so we try and work with the woman again where she's at. So we don't want to tell her what method to use, but we do provide education on what is the most effective. So we might start with, did you know that an IUD or a long-acting reversible contraceptive is 99.9% effective, et cetera, et cetera. And so we have educational materials that really do tackle that issue of that range of effectiveness. We do talk about effective use, what that means, how to define that, especially like with pill use or condom use. For your first question, in terms of measurements, we have a couple of different ways that we're getting at what they're using and how effectively they're using it. And so our first question, of course, is if they're sexually active with a man, can they become pregnant? And then we go into what type of contraception are they on? So oftentimes we ask it in a yes/no fashion, and oftentimes our participants aren't on anything. But we do have participants who might be on the pill, and so if they say yes, they're on a type of contraception, we dig a little deeper in, are they using it effectively? And so we have definitions on there that we've taken from the CDC and other sources on effectiveness. And we, again, really work through, okay, if you're using something, how effectively are you using that method? And if you're not using it effectively, are you using a backup method? And most times, no, they're not.
Thank you, Jessica. So I have a question here from Brenna. Brenna, I'm going to summarize and ask, so Brenna's heard from the community that they work with that they want to involve all members of the community in their program. So this includes men, youth, women, and elders in their work. So Brenna would like to know, has there been any interest from your community to include more members than just non-pregnant women? And Brenna would also be interested in hearing about how you're measuring the constructs of cultural identity, practices, and social supports and connectedness. So 2 parts. I can repeat it if you'd like.
This is Jessica, and I'll tackle the first one and maybe have Michelle, if you don't mind, also responding to this one.
Sure.
So the first part, and I have it up here so I can read it. So the first part is, are there other groups of individuals besides women of childbearing age who are interested in this type of intervention? And the answer to that is definitely yes. And so we've included, especially with that formative work that we've done, we've included elders, we've included men and youth. Both Michelle and I currently have research projects that are looking at the choices intervention or some type of choices-esque intervention with youth, with adolescent girls. I know there's been a very recent focus on how do we include men and how do we also include like social support. And so to answer your question, yes, there's interest. And in some cases, there's active grants going on in those areas. Now, we always go back to what is that health outcome that we're trying to affect? And we're trying to affect alcohol-exposed pregnancies. And so our target population for this intervention, of course, is women of childbearing age. But we definitely realize that women have partners, have people around them influencing behaviors, have support systems maybe that could be emphasized in our interventions. And there's been efforts to do some of that. So I would be happy to answer questions offline if you were interested. It sounds like you're doing some great work down there. And so the second part of the question is constructs of cultural identity, practices, and social supports. So you're wondering about the questions that we're asking, it sounds like.
Yeah, so I can respond to that, and I would be happy to follow up with you, Brenna, to make sure that you have the reference for exactly what we're using in case it's of interest to your group. But we're using a 2-item scale to measure spirituality, just very straightforward how important spirituality or religion is in your life, from not at all to very, and how often do you spend time on spiritual or religious practices, from very rarely to every day. So just those 2 items related to spirituality. And then in culturation, 2 broad, there's 4 questions, 2 broad areas. The 2 broad areas are, how important is it to you that you keep your Native identity, values, and practices, versus, so it's sort of looking at both Native and non-Native identification, a non-Native identity, values, and practices. And then it's the same questions, but framed, how important is it that members of your immediate family keep their Native identity versus non-Native identity. And, you know, that acknowledges prior work that there can be, you know, identification with both Native culture as well as, you know, other cultural groups, whether that's sort of mainstream American culture or specific other cultural groups for people who have multiple, you know, backgrounds. So I could, I'd have to get the exact references for those measures, but that might give you a sense of how those things are being measured. And I'll just say that in choosing measures, I can say that we spent a lot of time with our whole team, the team that you see here on the screen right now, as well as our methodologist, Rich, who I mentioned at the University of Minnesota, picking our measures. And I think it's always a challenge in research between measuring everything that you would want to measure versus being, you know, practical and knowing that, you know, there's only so many questions people are going to be willing to answer simply from a burden on their time perspective. So balancing that burden with, you know, what are our core constructs and what are the most efficient ways to assess those constructs. So I hope that helps.
So I have a question from Jill. How will we hear about the results of your research?
That might be a question for you, Gladys and Crystal. Are more of these webinars planned? Obviously, we plan to share, I'll just say before turning it over to you on future webinars, but we are already planning some papers just based on, you know, like our methodology, and also outlining some of the work that Jessica described here, going from choices to native choices to next steps. So we hope to have things published about our work before the final results, if you will, are in. But I don't know what plans there are for future updates from this team via this webinar format, but I'm sure there are some.
Yeah, I can add on to that. So this is Gladys. A few of the ways that you can keep in contact and in the know about the different projects and the results of the research. So we have our website, p4nh.org/NCARE. You can also sign up for our listserv, so you can keep in contact and we'll let you know of upcoming webinars. And there will be future webinars planned for this research project and the others as they progress into the later stages of their research. So over the next few years, there will definitely be updates along that manner as well. I have another question from in the room here. Kara has a question for the team.
Thank you. Very interesting study, so thanks for sharing it with us. I actually have a couple questions about the biomarkers, the biomarker. The first one is about the measurement. I'm just wondering if you're measuring it at all 3 visits, and what does it really reflect? Does it reflect exposure in the past 24 hours or the past week? That sort of information. And then the second question is how receptive are the 12 participants to date to give you this biomarker? I'm just wondering if there have been any concerns from the participants about the biomarker.
I can speak to the biomarker a little bit. The biomarker is a approximately two week recording of alcohol use. And as far as the participants to date, we've had no problems whatsoever. We're explaining that it records approximate, like a recording of alcohol use, but that it isn't connected to their name. We personally don't ever see the results of it on an individual basis out here in the field. So we've had no problems with collections.
I think there was one more part. Kara wanted to know how many times, how often it was collected.
Yeah, thank you.
So that's at baseline and then 6 months. And then Marie can say more about how much is collected.
Sure. So the 5 fingers, there's like 5 blood spots on one collection paper. Some people are randomly selected for 2, and then they'll be re-randomized, or in the second collection they'll also get 2 at the beginning and 2 at the end, just for quality control. So then they'll do 10 blood spots. But we've had no issues with collections.
But just 1 finger stick, right?
Typically, there has been times where like a person has had to be poked more than once.
Thank you. So we have about 4 minutes left. I'll try to get through some of the questions here, but we'll do our best. The next question is, do participants self-select contraceptive counseling or to receive text messages, and how do you control for this? Which combines with another question that asks you to speak about the supported texts and what it includes.
Yeah, this is Jessica. So both the text messages and the contraceptive visit are optional. And so women self-select to make an appointment and go see a healthcare provider. So it's encouraged. It's discussed during the intervention, the choices intervention, but it's not a requirement. I mean, none of this is a requirement, obviously it's research, but they're not required to go see a healthcare provider. They're also not required to do the text messages. And we'll have to work with our methodologist to really look at who is it that is self-selecting those two optional parts of the intervention. What does that impact? How does that impact? I will say that just based on some of the feasibility work that we've done, we know that a lot of women do choose to at least meet with a healthcare provider, if not get on contraception. So when provided with that referral, a lot of women do take it. Now, in this case, we don't know yet. We have an N of 12, but I anticipate it would be very similar. What was the second part of that? Talk about the text messages.
Yeah, what do the supportive texts include?
It's a variety of things. And so we are providing them with support, just general like support. We're also in some of those text messages, we are providing them with information on alcohol or contraception to kind of continue that engagement. In the original choices and in the work that was the preliminary work that was done, we didn't have this. And so this text message is a new part of this specific grant. And so some of those details have just recently been worked out. So it'll be interesting to see who opts in, how they receive the messages, does it impact anything? But it's another way of providing social support, essentially. I don't know, Michelle, if you have anything you want to add to that.
I think just to highlight that, there's 3 broad categories, which you've already touched on a little bit, but just to recap. So there's messages that are just generic, positive, supportive type messages. One, for example, is you make decisions about you, you're doing great. And then there's some question or messages related to, suggesting change, either related to drinking or birth control, which again are 2 key outcomes. And then some of just to promote knowledge or provide information, as Jessica said, about since alcohol-exposed pregnancy, knowledge as well as FASD knowledge is one of our outcome or one of our intervening variables that we think results in making changes to those 2 key outcomes. So I think we'll be working with Rich to determine how we put this into our analysis, given that it's optional. And I guess to that point, and I know we're almost out of time, Marie, how many people do you have just a ballpark sense of how many opt into the text messages?
I believe there's 3 that have opted into the text messages, and it's only available to people that are in the intervention.
So 3 of the 6, yeah. Great. So half.
Yep.
So far.
Okay, maybe one more question and then we'll wrap up. So Judith would like to know, given the high rates of dropout from the 2 preliminary studies, how do you hope to prevent high numbers of participants lost to follow-up? This might be particularly difficult for control group.
Wow, that's a good question for the very end. So I think it's a definite concern. Marie, I don't know if you want to speak to how Missouri breaks, because you have other research studies that Missouri breaks and other studies you've worked on, how you deal with loss to follow-up and retention.
So I don't know what preliminary studies we're referencing, but for the most part, Missouri breaks doesn't have a very high dropout rate. So I guess we will see how proceed with this as it goes.
Yeah, and the preliminary studies are referring to some of the other choices stuff that I've worked on and other folks have worked on. So
okay.
So I think it's just potentially working with a very local, tribally run organization will really help with that, with the retention.
Wonderful. Thank you everyone for joining us on the webinar today. I do want to bring to your attention that we do have an evaluation survey that will pop up once you exit the meeting. Please do take a minute to complete the survey. It will help us to plan future webinars and to provide feedback to the center here. Thank you very much. Have a great day.